Our next speaker, assuming the electrons crossing the Atlantic work, is Hugh Barr, who has for many years directed the Center for Advancement of Interprofessional Education in the United Kingdom. I guess it still is the United Kingdom after the vote in Scotland, right? I don't have to change my lexicon for that. Hugh, are you with us? So we have our technical people trying to trace the missing electrons across the pond.
Hello.
Ah, Hugh, good morning. Malcolm Cox.
Hi. Can you hear me?
We can hear you now, loud and clear, I believe.
Good. Okay, that's fine. Thank you first for giving me the privilege of joining in your forum and especially eavesdropping the discussion over the last hour or more, which has been hugely illuminating and helpful. I'm sorry we're not Skyping. Not that you need to see me, but I would love to have seen your faces. I do remember the room you're meeting in, so that's a little bit of a help. Thank you, Matty, for your wonderful presentation. You and I have spent many hours together talking about interprofessional education and collaborative practice, and anybody in the room who was imagining that we were going to take very different views will, I fear, be disappointed. I will, however, because this was my brief, remember that I'm coming literally from a different place and trying to present a different perspective. More precisely, several perspectives, and in the time available, I'm sure I'm going to fail to do justice to all of them. I have given Megan a copy of my notes from which I may well depart, but she has them. More importantly, they contain a number of references which I think are helpful now and maybe to the committee in the future. Can I pause at this stage and just double check that it's clear enough at your end?
Yes, Hugh, it's clear.
Good, lovely. Okay, fine. I want to go back by way of beginning to something on which Matty touched, and those are the various systematic reviews into the outcomes, efficacy of IPE, referring, if I may, to two that we did in the UK shortly after the turn of the century. And I think the distinction between them, unless I'm mistaken, may be critical to the task which the committee has set itself. The first, as you may recall, was a Cochrane collaboration review constrained by the strict, narrow criteria, which largely eliminated what might have been very interesting examples of evaluations of IPE, and in the end delivered nothing. The second, by a reconstituted group, decided to be less restrictive, and the outcome was more productive. The critical shift in our thinking, and I should say at this stage that Scott, who is in the room with you, was one of the group of 5 who did this work, so you have ample opportunity to quiz him about it later in the day. But the critical distinction was that we were no longer thinking about IPE as if it was a single entity leading to a single outcome. And with hindsight, that sounds pretty naive anyway. We had begun to realize that there were many different types of IPE, as Mattie said in the title for her presentation, many types leading to many different outcomes. And we found the work of Kirkpatrick, an American, dated 1967, when he set out a series of outcomes along an ascending scale, especially helpful. Our findings from 107 worldwide examples of IPE that met our selection criteria found that those, in your terms, not mine, that were pre-licensure, under favorable circumstances, met intermediate objectives, by which I mean that the outcomes were to do with establishing knowledge bases shared between the professions and relevant collaborative practice, and/or modifying reciprocal attitudes between the participant professions. In contrast, the examples that were post-licensure demonstrated impact directly, or some of them did, on patient experience and/or the quality of care. These were examples worldwide, something like 2/3 from North America, 1/3 from the UK, and a very thin spread throughout the rest of the world at that time. Now, the data we're talking about was going back to the turn of the century, sometimes earlier, and the critical question must now be whether more than a decade later, pre-licensure IPE has sufficiently improved to give us reason to be hopeful that its outcomes will move further along or up the Kirkpatrick scale. I'm waiting to see, and I know Scott is, whether the BME review, Best Evidence Medical Education Review, which he is leading and started work in the last few weeks, generates data which is illuminating in those terms. For my part, I'm really quite cautious, and one reason for being cautious is that in the meantime, three of us have conducted a review of the interprofessional pre-licensure learning process in the 4 countries of the UK. Many of the findings, and I'm not going to spend a lot of time on them, are exceedingly encouraging. At least 6 out of every 10 relevant universities with healthcare courses, including IPE, and an astonishing level of dedication on the part of those who lead. However, there are a number of findings which give us cause for concern. The first of these, Mattie, refers back to something you said towards the end. We find a lack of alignment between the pre-licensure courses into which the IPE is implanted. We find, secondly, that unilateral changes are made by management, sometimes by regulatory or professional bodies, regarding the aims and content of one of the professional courses, disrupting the basis on which they come together to share interprofessional education with others. We found, thirdly, a lack of commitment, a lack of culture in the practice world to support what we deem to be effective interprofessional practice learning. 2 more. very clearly with that, not much in the evidence we collected. It might be a weakness in our method, not much to suggest partnership between universities and the practice agencies responsible for the placements. And finally, and it links again, limited evidence of participation by patients and carers in the planning and delivering of the teaching, which again, I think Matty picks up on one of your points. So our findings pointed on the one hand to the need to improve pre-licensure IPE, but on the other hand, I think to recognize that it will always have its limitations, and building on the basics is therefore critical by means of continuing interprofessional development, which I shorthand not as CPD, but as CIPD. During the years which we've been working, expectations of IPE in your country, mine, and others have risen very, very rapidly. And you've referred to all of them, Matty. I pick up quality improvement, patient safety, and especially concerns in your country to reduce costs. The danger is that the expectations are outpacing our capacity to respond within our current understanding and resources. I was asked when I was briefed to contribute this input to say something particularly about the question of costs. If I'm honest, I would prefer to have ducked the question, and it's not one that comes through very strongly in the UK, notwithstanding our tremendous concern about economizing and cuts in education and practice. It did, however, come through very forcibly to me when I began to become more involved in interprofessional developments with a Spanish colleague, Juan José Beonza. In Spain, they are currently in the midst of something like a 50% cut in public expenditure. To try and avoid the cost-cutting question is inescapable. It cannot be done in their context. So I agreed with some trepidation, and it's in the references, to write a joint chapter trying to take a look at what this meant. In essence, and this is oversimplifying like mad in the time available, the message is that we need to invest in the interprofessional education in the expectation, if we plan its strategic outcomes accordingly, that there will be savings further down the line in terms of the costs of treatment and care. And this refers, and this is the one that we spell out most obviously, to delaying admission to hospital and reducing the period that the patient spends in hospital. We could have gone into the much more troubled waters to do with substituting paraprofessional workers for professional. The arguments about dilution, sometimes hidden in issues to do with workforce development. We decided not to do that, but, and I'm about to move in this direction in my remaining time, when we begin to think about IPE and collaborative care in poorer countries, that issue also becomes inescapable. Bear with me in the limited time that I have if I do not attempt to give you an overview of the huge variety of interprofessional education and practice in developing countries. But from my recent experience, just let me give you the flavor in terms of some of the people with whom I'm currently working. There is the psychology teacher in Islamabad, in Pakistan, running interprofessional workshops about post-traumatic stress disorder and endemic drug abuse in his home region, the war-torn Swat region. There are the students in Indonesia pressing their teachers for better professional and interprofessional education. There is the civil servant in Kenya who explained to me how tribal obligation and custom impacts on the manner in which collaborative practice is organized. There is the PhD student in Iran who shared with me the teaching from the Quran about collaboration, which will form the first chapter of her thesis. There is another PhD student studying in England, coming from Turkey, who is helping me to track down interprofessional activists in individuals and groups scattered across the Middle East and African countries. And finally, there are the teachers and students in Qatar who have responded recently in a most encouraging fashion to our approach that they might host the first Middle Eastern and African interprofessional conference. The issue, and I leave it hanging, is does our Western experience, assuming a broad comparability between the US and the UK, does our experience, like good wine, travel? I think my answer, and again I leave it hanging, is yes and no. I'm surprised as I go the rounds how often IPE in developing countries resembles that you would find in the States, Australia, Britain, and so forth. And that might be something to do with post-imperialism. On the other hand, I think if we probe deeper and look at the nature of collaboration in its indigenous culture, the differences may be more pronounced. So the message, I think, is to be extremely cautious in assuming that the powerhouse driving developments in, say, the US can transmit its messages to the wider world without pausing and spending more time than we can this morning in looking at their experience from their perspective and in their terms. The consensus from your deliberations to do may well help those of us beyond American shores to delineate more clearly than we do presently between types of IPE and their outcomes within, and I repeat here, a career-long continuum interweaving professional with interprofessional learning. Whatever your report says, and I look forward to it, we will be looking at it critically, testing your arguments and assumptions in the context of our experience, whether it's in the UK, Europe, or beyond. The awakening in the wider world, I think, is a response to the forces driving the Lancet Commission, the Frank report. I don't think it was the report itself. I think in many ways that is itself a response to the underlying forces at work. Jill Thistlethwaite, who is with you this morning, John Gilbert and I welcomed the report in a letter to the editor of The Lancet and called on professional bodies worldwide to write the competencies for collaboration into their requirements. Whether that is happening may be perhaps too soon to say. In a review of the report for the Journal of Interprofessional Care, I challenged the interprofessional movement to demonstrate to Giulio Frank and his colleagues what it was already doing to realize their vision and its readiness to volunteer its experience and its expertise to join in common cause. The parallel preparation of the Lancet Commission report and the WHO framework was a sadly missed opportunity for them to confer with each other. The Commission's views do, however, resonate more clearly in the 2013 WHO guidelines for transforming and scaling up health professions education and training, which I think is attracting less attention than they merit. The guidelines include 11 recommendations for improving health professional education, of which CAIPEI is one. However, the banner under which the WHO is now flying is transformative, not interprofessional learning. Leaving, and we're so being encouraged, leaving interprofessional activists to enter blogs and Twitters on the WHO website. Twittering is not enough. There is a compelling case for reminding the WHO, and I stick my neck out here and say the WHO, which tends to blow hot and cold concerning matters interprofessional, to remind it that CAIPEI is indispensable in transforming health professionals' education. Finally, the Institute of Medicine enjoys the authority to be heard by the WHO. Thank you.
Hugh, thank you very much for that response and extension of Maddie's presentation. I think the perspective from different regions of the world is really critical, and I'm humbled by what you've put on our shoulders for this committee to deal with, not just within the United States, obviously, but globally. We have just a few minutes before we have to move on, but I wonder if the committee has any questions they'd like to direct to Hugh. Scott and Barbara have questions, so let's be focused.
Okay, Hugh, just a very, very quick question. You mentioned some really good examples across the world, and some of which I know. Do you know if there's any evidence attached to these examples? Because that's one of the things that we're sort of looking at in trying to sort of collate and understand.
Well, I mean, I hope, Scott, that in our BME review, we will find, as we found a decade ago, some examples from countries where we're least expecting them, and they may well be included. If Barbara Brandt's about to chime in, I'm recalling some remarks she made in a discussion only a week or so ago of the need to find ways of valuing evidence which is not subject to peer review appearing in learning time-honored journals through the time-honored process, but has a different kind of validity and pertinence. And I'm persuaded, but in a not very scientific way, by the people I talk to, for example, in Pakistan, who are highly professional, that they are delivering highly significant interprofessional education in line with what you and we are looking for. But I don't think there's any easy answer to draw this wider spread of countries into the peer review, systematic review process, which we have and want to hang on to.
If you, Barbara, you had a comment.
For your remarks. This is Barbara Brandt. I don't even know if I have a question. I have an observation. And as you can well imagine, I do feel the heat of this topic pretty significantly. I guess my comment and observation is the world is changing very quickly. We had an Uber example, and that's a new transportation system developing in the U.S. that's going directly to the people. And it's challenging the structures and the regulations and the way we view the world. My concern is healthcare is changing in the United States, at least, I think, very quickly. And we are seeing patients, families, and communities being engaged in new ways. My concern is we're sitting here, we're thinking about metrics, we're thinking about outcomes, we're thinking about evidence, and will the world change too quickly by the time we figure out what those should be? So you yourself have noted that this is not an easy task, but how do we view this? And I guess selfishly in the United States, when we are going through tremendous change in the U.S., how do we view IPE in a different way? Then I want to make one other comment. I've actually, when I give talks now, am being challenged that the term interprofessional in and of itself is too limiting because it is not inclusive of all the people who need to be involved in whatever the movement is that we're involved in.
Amen to your last point, and I think this is something coming through very strongly in talking to people, with people from a wider spectrum of countries. The language we use is indeed quite restrictive. The speed at which instances of interprofessional education are breaking surface is breathtaking all over the world, and I think we're at the point where we should begin to assume that things are happening somewhere in every country, unless we're very sure to the contrary. This is not going to wait for the United States or the United Kingdom to come up with clever answers to complex problems. These people have their own reason for getting on with their groundswell of change in education and healthcare. And I think it's it's a whole different level of communication between themselves, which is, if you like, of a lower order than the kind of task that you've set yourself for the forum. But it's the real world of change, and it will gather momentum in the coming years.
And a final question from Brenda Zerler.
Thank you very much, Hugh. My question is, and actually a plea to people like you who do these systematic reviews, but also are on editorial boards, and that is, it relates to the quality of data that we publish around IPE. And I think having almost a technical type paper like the journals that require from a comparative or cost effectiveness paper, requiring people to talk about the dose and the timing of the IPE, the level of learner, the faculty development associated with that activity, and what is the one skill they're hoping they'll transfer into practice, and maybe even where on the Kirkpatrick scale. And I'm talking about a more systematic approach, because when you review the literature, it's like the students really liked it. They got together. You don't know what level of students. Was it mandatory, voluntary? There's so much data missing, and I think unless the journals can make a plea that you can submit this paper, but here's a technical component that anybody else could review, and that's how we're going to scale this up, because we can't repeat these small little things that the students liked it. We don't really care if they like it, what they learned from it, what was the goal and objective for moving it into practice.
Yeah, I mean, I'm probably going to land up having an argument with Scott next time I see him. We've got a long journey together next week, so that will be my chance. But I think that there's a danger that in the learned journals we become more and more focused on a particular systematic approach to reporting evaluations, which I absolutely applaud, but to the exclusion of a huge amount of other material which may somewhat pejoratively be regarded as descriptive, which is nevertheless the literature and the experience of the vast majority of people in the wider interprofessional community. And I think we need to find a way of opening that out. I think the other thing, and this is something I've been trying to do with CAIPE and with my colleagues here in the UK, is to be more outward-looking in how we write. Yes, there is a place for talking to the cognoscenti in the language which we've come to expect and appreciate, but we've also got to find a way of turning that round and use plain English and find simpler ways to express the significance of what the movement is all about to people who are not part of the inner circle.
Thank you, Hugh. Your plea for plainer English, or I would say plainer language, to be more global in our thinking about
Yeah, accept the correction.
is absolutely critical. Thank you very much. We need to move on then.
Thank you.
To pay homage to two people who had different parts in preparing a background paper for the committee. And Tina Brashers and her team at the University of Virginia spent many hectic hours, I'm sure hundreds of hours over the last couple of months, expanding and redeveloping some of the thinking and some of the data on outcomes of interprofessional education. And so we're going to have Tina present a brief summary of a much larger paper that she has produced, which will become part of the work of the committee. And we thank you so much for doing that. And then we're going to have Jill Thistlethwaite, who's a fellow at the National Center for Interprofessional Practice and Education at the University of Minnesota, respond briefly with some of her thoughts about that. So over to you, Tina.